So this is the first case. A 56-year-old man was brought to the emergency department because of cough, shortness of breath, and abdominal pain. The emergency doctor on examination noticed that there is suspected pleural effusion, which which he confirmed on the X-ray, and there was hepatomegaly and splenomegaly as well. The full blood count shows hemoglobin of 110, white cell count of 103, platelet count of 110. So this is the blood film, and I would request any of the lab staff to comment on the blood film. How would they report the blood film for a clinical hematologist? Do we have any lab staff to comment on the blood film? I'm asking from the lab staff because I was told that I should give equal opportunities to both lab staff and clinical hematologists. So if there is any lab staff available, he can come up and comment on the blood film, please. Right.
You
So
mean
I
to
think
say, you mean to say lab hematologist?
yes, any
Okay.
biomedical
Okay.
scientist, medical
Okay.
technologist, anyone, like because the blood film is first seen by them, and then they escalate the film to us. And in previous sessions, many of the lab staff messaged me that we need equal opportunities. So I want lab staff first to comment on the film, and then obviously this film will go to clinical hematologist, and then we will ask from the clinical hematologist to comment on it.
Right. So we should wait for them.
Right. So if the lab staff is not available, then I will act as a lab staff for this slide. The blood film shows leukocytosis. The lymphocytes are the white cells are small in size with some projections from the cytoplasm. The red cell shows few schistocytes, and there is thrombocytopenia, but no platelet clumps seen. When referred to clinical hematologist for further opinion due to suspicion of acute leukemia. So these are the comments that is made by the lab staff. So now this film has come to you. You are the clinical hematology registrar, and you are sitting in FRC Part 2 exam. The first question is report this film. I will make it to power 10 again. All right, so now I need a clinical hematologist to comment on this film and report the film. Anyone?
I can try.
Yes. So this is power 10. I'm giving you a general overview of the film.
Mhm.
All right, and now I will move to power 50, oils blends. Yes. So let's see a few slides and then you can start reporting the blood film. Yes. So report the blood film. You are sitting in FRC path exam. How would you report this one?
The film shows leukocytosis with predomination population of atypical lymphoid cells, which are variable in size but mainly small in size, having high NC ratio, condensed nuclear chromatin, and some of the these atypical cells they have glebs, cytoplasmic glebs in them, inconspicuous nucleoli. The RBC morphology shows mild anemia and few fragmented and papillocytes are seen, and there is thrombocytopenia and no clumps.
Okay.
The peripheral film findings are consistent with a lymphoproliferative uh, disorder, most likely TPLL, and I would like to confirm my diagnosis with flow cytometry on peripheral blood for lineage specificity. I don't know whether I have to comment on the basis of this morphology that these may be TPLL cells.
They look like TPLL cells because they are small, mature, and have cytoplasmic blebs, which is the feature of TPLL. You would not say definitely that this is TPLL. You would say most likely it is consistent with uh, TPLL. So I need flow cytometry to to confirm my suspicion or to confirm this diagnosis. So what is the expected flow here?
Usually these cells are CD2 positive, 3 is weak, they are 5 and they are 7 positive.
Any other significant marker that is important for treatment purpose?
Is CD52, I guess, to give alemtuzumab.
Yes, CD52 is positive, and that determine the treatment as well, which is anemia. Are you aware of any genetic mutation?
Yeah, mostly they have inversion 14 and also the abnormalities of chromosome 8, and on molecular genetics they have, I'm not sure, there is something MTCP1 or TCL1AB mutation. And they
Yes,
also have
MTP1.
they are also associated with ataxia, telangiectasia, and they have ATM gene rearrangement abnormalities.
Yes, ATM gene mutation is associated with multiple things like mantle cell lymphoma and multiple myeloma as well. But here, more than 90% of the patient shows MTCP1 rearrangement, and the flow cytometry you have mentioned, treatment you have mentioned, which is alemtuzumab. So this
Sorry,
is
which rearrangement? Sorry, more than 90% have which rearrangement?
MTCP1.
MTC. Okay.
Yeah. So this is TPLL, mature T cell leukemia, and it comes as a short case in the part 2 exam, where they ask the what is the report the blood film, which carries 6 marks, and then expected flow 2 marks, expected cytogenetics 2 marks, sometimes 1 marks, and then they ask you what is the treatment of choice for these patients, which is alemtuzumab and transplant in first remission if they are symptomatic. If not symptomatic, then watch and wait uh, is the policy. So TPLL cells are small, and their characteristic features and morphology are these blebs. They carry a lot of blebs like that. Some people call them Mickey Mouse cell, but I think this is not correct. Sometimes they have many blebs, not two blebs. So anything that can help you in retaining the information for the exam purpose is useful. Right.
So how do you comment on the chromatin of these cells? As for me, it is difficult to pick. Is it a blast or a mature T cell?
Blast is usually large in size, um, and open chromatin with nucleoli visible in it, while these cells were very small and the chromatin material was very dark blue and nucleoli were not visible here. So this is a feature of mature um,
Right.
leukemia and lymphoma. You see these features in CLL as well, in follicular lymphoma as well. They are very small. Their nuclear material is very uh, dark blue in color, and nucleoli is not visible. You will compare it with now another malignancy who has a large blast with prominent nucleoli, open chromatin, and some have multiple nucleoli as well. So
Right.
this, you will see it in the second case now.
Sorry, how do we differentiate it from the megakaryoblast, which also have the cytoplasmic projections? Thank you.
Again, megakaryoblast, they are a bit bigger than um this TPLL cells, and they have specific appearance. I will bring that film next time. I have one film for acute megakaryoblast leukemia as well. We call it as blebby AML. I will bring this film next time, and I will also show the TPLL to you as well to see the difference between the two. The megakaryoblast, they are not as deeply blue color like these cells, and they are bigger than the TPLL, and they are not as much in number as these TPLL cells were. TPLL, one of the features of TPLL is that they are very high in number. Usually, when they present, they cross the mark of 100 in the peripheral blood. While the megakaryoblast, they are not that much. They are big in size, not that deeply blue color or basophilic color, and they have quite a lot of blebs and irregular markings of the cell. We will see that in the next session for the acute megakaryoblast leukemia.
Thank you. Okay, thank you very much.
All right. So this is a second case. This is again a 56-year-old man presented to ED with significant weight loss and night sweats, decreased appetite, He has inguinal and axillary lymphadenopathy on examination, and he looked very tired and fatigued. This is the blood film from the patient. His white cell count shows hemoglobin of 98, platelet count of 93, and white cell count of 60. So again, I would need a lab staff first to comment on this film.
So the peripheral film of this patient
Are you
is
one of
shown.
the lab staff?
Some lab hematologist.
Lab hematologist. Okay, right.
So
So
this peripheral film is showing leukocytosis, predominantly lymphocytes are seen of small to medium size, and there is thrombocytopenia on this power of lens. Okay.
so this is the power 50 now, and this is a Nikwa slide, so the quality is a little bit um, low as compared to other one.
Right. So these are not lymphocytes. Um, they appear to me as monoblast. Okay, these are large cells with low NC ratio. Um, these are large cells with low NC ratio, open chromatin, uh, few having conspicuous nucleoli, and the cytoplasm is agranular. There is moderate to copious amount of cytoplasm.
Hmm.
Few cells having indentation, nuclear indentation. So these are blast, most probably of myeloid series.
You said that this is agranular.
At that power, I said agranular. Yes, there are granules, but very few.
So you can see these blasts have multiple nucleoli, some small nucleoli, some large nucleoli, but they carries multiple. And they are quite large as well.
Yes, most probably the monoblast.
No, they are lymphoblasts because we cannot see um, any indentation. The monoblasts have very few indentation, but the cytoplasm here is not blue. There is no vacuole, and monoblasts do not have this clear nucleoli like this cell have. This is a lymphoblast.
Right, sir.
This is
Sir,
tumor.
are these large granular lymphocytes?
No, no. They may have very few granules, but most of them are without granules.
Ji, sir.
Like this one, I will make it to 100 power again. You can see they have multiple nucleoli.
Dr. Ramesh, usually lymphoblasts, they don't have the nucleoli. Initially, we used to classify them on the basis of Fab when they were L2. Then the L2 cells they have nuclei, but usually nuclei is not a feature of lymphoblast.
There is one lymphoma whose feature is having large blast in the blood film with multiple nucleoli. So they have prominent nucleoli here, this one, this one. So the patient has features of B symptoms, lymphadenopathy, large lymphocytes, lymphoblasts with multiple nucleoli. Um, I will try to find out few lymphoblasts which carries vacuoles as well.
It can be blastoid variant.
Like, how you are going to differentiate between the blastoid variant of some NHL and the lymphoblast on morphology?
So the blastoid variant of mantle cell lymphoma have blast, but they are not that much big. They are medium sized. These blasts are very large in size with multiple nucleoli, and patient has full-blown symptoms of lymphoma. So a lab staff would report it like this. The blood film shows leukocytosis. The uh, there are multiple blasts which has bunten cytoplasm with open chromatin and multiple nucleoli. There are few smudge cells as well. Red cells shows anisopocytosis. As you can see, their shapes and size are different as well. And there is thrombocytopenia and no platelet vaccines. So this is the report for the lab scientist or biomedical scientist, and then they would say refer to clinical hematologist. Now this film is with you as a clinical hematologist, and you are sitting in a Path exam. So you have seen this film. What comes in your mind as a differential diagnosis? Large lymphoblast with multiple nucleoli, lymphadenopathy in the patient. Say something.
Sorry, LGL,
Sorry? Can
large
you
granulocytic LGL.
LGL patient does not have the B symptoms like this severe this patient has. This patient has lymphadenopathy everywhere. LGL comes in context of SLE, rheumatoid arthritis, Sjogren's syndrome, in presence of any other autoimmune disease. This patient has all the symptoms of lymphoma.
LDL,
So in
And
DD,
LDL,
DLBCL can come. DLBCL.
yeah, this is the
or
feature of
LDL.
DLBCL. Their blasts are very large, and they have multiple nucleoli in their chromatin, which is visible. Mantle cell lymphoma or blastoid variant of mantle cell, they carry blast as well, but they are medium size and they carries only one nucleoli in it. This this patient has large blast with multiple nuclei. You can say some cells has 3 or 4 nucleoli, and this cells has a lot of multiple nucleoli, small in size. This is the feature of DLBCL. So if you are working in NHS and you have lab access, go to your lab and see the film number 2302. So this film must be present in your lab, in NHS lab 2302, and you can see the full comment of the Barbara Bain on this film. He has mentioned as well that these are large blasts with multiple nucleoli. Features of this is most likely a high-grade lymphoma. We need to send blood for urgent flow cytometry uh, and other investigations to look for any um, lymph node which is amenable to biopsy. All right. So this is a high-grade lymphoma, and you have sent blood for flow cytometry. What is the expected flow here? Immunohistochemistry expected.
These cells, if they are DLBCL, then they should be CD10 and CD20 positive and should be 5 negative. And also we'll ask for the MYC gene rearrangement. If it is positive, then you go for BCL6 and BCL2 to label whether it's a double hit or a triple hit lymphoma.
Yes. Okay. And let's say this patient is fit for treatment, and you want to assess this patient for CNS prophylaxis. What you will do to assess whether he is fit for CNS prophylaxis or not?
For CNS prophylaxis, you will do the CNS IPI.
Okay. So, who are the patients to whom you will offer CNS prophylaxis?
I don't remember exactly, but maybe those who have stage 3 or 4 with extranodal disease involving the testes, the breast, the uterus.
Okay. So, those patients whose CNS IPI is high, 4 to 6, or if they have three or more extranodal sites involved, or they have specific anatomical sites involvement like testicular sites, adrenal gland, renal involvement, or even intravascular DLBCL as well. And especially in a case of female, if breast involvement and uterus involvement is there, then you offer the patient CNS prophylaxis. What do you offer in CNS prophylaxis?
Intrathecal methotrexate.
It's not always
No,
intrathecal
but
methotrexate.
high dose methotrexate.
Yes, it is high dose methotrexate if the patient has any contraindication for high dose intravenous methotrexate like effusions or poor renal function, then you go for intrathecal methotrexate. Otherwise, um, you just give them high dose methotrexate IV. In any sort of ascites or effusions, you also avoid uh, uh, high dose methotrexate because there is a chance that uh, the patient will accumulate methotrexate over there and can lead to toxicity in the future. So these are the big cells of DLBCL. If you are working in NHS, go to your lab and see the film number 2302, and you should see this high-grade lymphoma. Okay. Right. So this is the third case. This case is directly for the clinical hematologist. Uh, this is again 56-year-old male who is complaining of low back pain. The full blood count shows anemia and thrombocytopenia. Hemoglobin is 90 and platelet count is 90 as well. On examination, he has some splenomegaly as well. So low back pain, anemia, thrombocytopenia, and splenomegaly. Because of the persistent thrombocytopenia and anemia, bone marrow biopsy was done, and this is the trifine. So anyone who is volunteer for this case? Anyone? Inas al-Bashir on the list. Noor Omar, Iman Osman, Azar Rajab.
Hi. Hi, Amir.
Yeah. So I have told you the scenario,
Yeah.
and this is power 4. I will just go through the refine to see whether this is a good size or not, and whether there are enough trabecular spaces or not. This is power 4 to give you an overview.
Okay.
Yeah. So Trefine usually have um, some features that you should remember for the exam. And once you see them, the diagnosis should be very clear to you. Like follicular lymphoma has specific features, CLL Trefine has specific features,
Mm-hmm.
mastocytosis has specific features, DLBCL is very easy to pick. Hodgkin lymphoma, if you are able to see the ovali cells, it is good. So this is, you can see a Giemsa stain.
Yeah.
So this is one clue to you why I have brought a Giemsa stain. Okay. Similarly, myelofibrosis, Trifine has very specific features as well. So now you have seen the length, you have seen the trabecular spaces, and you have seen the trabeculae as well. I will go to power 10 now. Okay. So this is power 10. And again, you have to comment on all the lineages. If you know the diagnosis, doesn't matter, but you have to report it as it should be for the exam purpose, including length, cellularity, trabecular spaces, trabeculae, lineages, any abnormal features, and then your impression and suggesting uh, flow cytometry or immunohistochemistry. If you have seen such refine before, the diagnosis will be very, very clear to you. All right. Do you want me to go to power 50 or you have found the enough features here?
Sorry, my internet was had a poor network. I was disconnected and come back again.
Mhm. Yeah. So do you want me to go to power 50 or you have found the enough features here?
Now, can we go to power 50, please?
Because if I go to power 50, most of the people will get the diagnosis on the spot. Those who knows should get the diagnosis now, just from this view.
Mm,
No. So
not
now you
really.
can. Oh, okay. All right. No, no problem. You can report the um, refine. How would you report?
Okay. Um, so is that similar to the aspirate, like to comment on the initially on the low power, on the cellularity,
Um,
or the same approach for the
first,
aspirate?
first comment on the length and adequate, whether the sample is adequate or not. So this is a good length sample, a good length and adequate sample. Sometimes you will find a refine slide which is fully crushed or end of the refine is crushed. Like this refine is crushed at this
Yeah.
point. Yeah. So so this is a good length sample with crushing at one end, but the rest of the trabeculae are preserved. The trabeculae,
Yeah.
they are thickened. They are thickened because of the underlying disease.
Okay.
Yes, megakaryocytes are present. You have seen a lot of megas here.
There are, yeah.
Yes, we cannot comment here on the myeloid lineage because the stain is giemsa. For that, H&E stain is better. But you have seen there is peritrabecular fibrosis, and there are a lot of spindle-shaped cells in the peritrabecular area, which gives a suspicion of um, systemic mastocytosis, but that need to be confirmed on the immunohistochemistry and
Yeah,
uh, blood level of tryptase. So these are
yeah.
all the spindle-shaped cells. These are all the mast cells. So um, uh, if your hospital is a tertiary hospital, there must be HMDS. Usually, most of the tertiary hospital have HMDS as well. You can get the performer of the bone marrow biopsy reporting from there from them. So you can see these are all spindle-shaped cells. They are all mastocytes.
All right.
Yes, and mastocytes are better seen on gem sustain. So if in the exam, if you see any gem sustain, it will be for the purpose of systemic mastocytosis. But presence of gem sustain does not mean that you jump to uh, systemic mastocytosis. See other features as well. Patient usually have bony pains. They can have neuropsychiatric problems as well,
Okay.
hepatomegaly, splenomegaly, anemias, because in systemic mastocytosis, we have either indolent form or smoldering form or advanced systemic mastocytosis. Advanced systemic mastocytosis usually comes with symptoms.
Okay. Sorry, Mir, but just for the spindle shape like cell, for me the cells look like more, like it's like elliptocyte or something, like it's elongated, but um, is that like where is like the characteristic spindle shape of mastocytosis?
Yes, mast cells are spindle-shaped cells mostly, and I don't have aspirate for this one. And
Okay.
aspirate, they are usually elongated as well.
All right.
Yeah. You see mast cells in Waldenstrom as well. The nodules of Waldenstrom lymphocytes in Refine are surrounded by mast cell. This is the feature of Waldenstrom. If I get any Refine for that, I will show it to you.
Okay.
So, Dr. Amit, uh,
Uh,
if they have given you the Gimsa stain for systemic mastocytosis, we don't comment on the granulocytic lineage and erythropoiesis. We just comment on the length, adequacy, the length, the cellularity, and the trabeculae, and the main abnormality. We don't
if
comment on erythropoiesis or leukopoiesis.
if you are good in gym sustaining, then you can, but I am not good in gym sustain refine reporting. I always use HNE stain for refine report. But if
I'm
you,
asking for the examples.
yes, ideally we should comment on the myeloid lineage and the erythroid lineage as well. But if you are confident that whatever you are writing is correct, uh, is okay. But if this was H&E stain, I would have commented on myeloid lineage as well, on the erythroid lineage. Megas were visible here.
Sir, there any other differential that should come in mind except systemic mastocytosis if bone marrow trypin is given with gemcitabine?
For the exam purpose, it is only the systemic mastocytosis. But in real life, I'm not sure whether uh, is there any other diagnosis which we made from gemcitabine. In the lab, we make both for both slides, H&E stains and James stain for every disease. But for the exam purpose, it is the James stain that comes for systemic mastocytosis. Like if
Yes,
you
sir.
have any bone marrow for myelofibrosis, for ET, for AML, they both would have GIMSA stain and H&E stain, but the reporting is more on the H&E for exam purpose. The lab staff, they are histopathologists and consultants. They know what to pick from GIMSA stain in those cases. But I'm just talking
Yes, sir.
about the exam purpose. Right. What is the criteria of systemic mastocytosis diagnosis?
There is a major and a minor criteria. The major criteria includes the presence of dense clusters composed of more than 15% mast cells and aggregates in the marrow and or in any extracutaneous tissue. The minor criteria include more than 25% mast cells, which are either spindle shaped or having an abnormal morphology, the presence of KIT mutation and CD2117 and CD25 expression on mast cells and serum tryptase, CD immuno, the four things in minor criteria. More than 25% abnormal spindle shaped mast cells. Second would be the KIT mutation. Third would be the expression of CD2, CD25, or I think 117
13.
on the mast cell. Sorry, 30? Okay. 30 on the mast cells. And the fourth would be the serum tryptase, which would be more than, I think, 20 nanogram per ml.
Right. So if this patient has KIT D816V mutation plus PDGFRA mutation as well, what is the drug of choice?
KIT mutation and
PDGFRA mutation. You
TKI
can
inhibitor are.
yeah, this is a lot of eosinophils here. So the patient has PDGFRA and the KIT mutation both together. What drug usually do you give?
It's, it's apratinib. I don't remember exactly the name. Avapritinib, or it's KIT
Yes,
or
the new
PDGFR kinase inhibitor, both.
avapritinib recently.
Yeah, avapritinib.
Okay. So this is the fourth case. This is a 25-year-old male with recurrent fevers. He didn't respond to antibiotics prescribed by GP, and despite uh, 3 days of antibiotics, he is spiking high temperature. His full blood count shows hemoglobin of 98, white cell count of 9, and platelet count of 180. This is the blood film, and I want any lab staff to comment on the blood film first. Any biomedical scientist, medical lab technologist. Do we have any in the audience?
Sir, I can't comment on this power.
So this is power 10. I will go through the film to show you an overview of the film, and then I will move to power 50 and if required power 100 as well. Okay, so you have seen few slides on power 10. Now let's move to power 50. I'll put some oil on it.
Right, sir. So the peripheral smear of a 25 years old male with
Mhm.
low HP and normal platelet and white cell count is showing normocytic, normochromic red cells, and the ring um, single, delicate, or single or multiple. I can see the two ring forms also um, infiltrating the red cells. Yes, sir. Ring form of most probably Plasmodium falciparum.
Yeah, so most probably Plasmodium falciparum, and you need to confirm this on RDT and NET. So you mentioned that you are the lab staff, right?
Yes, sir. I'm a trainee for FCPS in Pakistan. I've
Okay,
completed my training.
all right. So then uh, I would request you to report this film as well for the exam purpose. Like you are sitting in part 2 exam or FCPS 2 exam. How would you
Yes, sir.
report?
So the ring forms of Plasmodium falciparum are seen. So we write like that. These are the normochromic normocytic cells infiltrated by the ring forms of Plasmodium falciparum that are delicate in shape with the.
You don't know yet that these are Plasmodium falciparum. You need to confirm that on RDT and NET testing because ring forms can be present in many other things,
Yes, sir.
or
Sir,
it can be.
can these affect the diagnosis affect the treatment options?
Yes, why not? We will discuss the treatment in a second now.
Ji, sir.
Okay. So, yes, comment on the blood film, please.
Um, Sir, I have commented already and I don't know how
Okay.
to comment.
So the blood film shows multiple ring trophocyte of malarial parasite. The red blood cell size is normal. There are few red blood cells with multiple rings in it. In some of the red cells, the ring is near to the red cell membrane. So this is equiliform, which is a feature of the uh, Plasmodium falciparum. There are few schistocytes in the uh, blood film as well, with low platelet count, and the white cell count is normal. The features of malarial parasite is most likely consistent with Plasmodium falciparum. We need to confirm this on RDT and NET testing.
You're right, sir.
Okay. Okay. Why this is not Vivex?
Sir, the differentiating points for the Vivex are importantly that they invade the early precursors of the red blood cells that are reticulocytes and that are large in size. So we can, and also the ring is not delicate, it is with thickened cytoplasmic membrane. And in this case, the Plasmodium falciparum invade almost all kind of the cells and also the mature cells, mature
Mm.
RBCs.
So this is the double dot appearance. So the red cell size in Vivex is large, and the ring trophozoite form of the malaria parasite is thick as well. So you must comment in your report about the red cell size, the ring features, if they are thick or thin, near to the red cell membrane, multiple or single. And usually gametocytes are not seen in the blood films. If you are lucky, you will be able to see that. But in this film, I searched for gametocyte, but I could not see the crescent form or banana-shaped form of the Plasmodium falciparum. Right. What is RDT?
Rapid diagnostic test.
Right. And what is the principle of RDT, rapid diagnostic test?
So pardon, repeat your question, please.
What is the principle of RDT?
Sir, uh, it is based on the we use as ICT kits, and there are two type of kits. Either the the coating film is coated by antibodies against the parasites, or they are coated with the antigens. So they detect the presence of the parasite. And in case of falciparum, there is histidine-rich protein that is detected. And in case of Vivex and other parasites, there is LDH.
Okay. So it is a lateral flow immunochromatographic antigen detecting test. Like it is the based on lateral flow method. It is immunochromatographic antigen detection test, which use a dye-label antibody to bind to the parasite antigen. Okay, and this complex makes a line in the result window. So just say it is immunochromatographic antigen detection test, which use a dye-labeled antibody against parasite antigen, and this complex form a line in the result window. Is there any condition which gives you a false positive RDT? Rheumatic factor, if present in a patient, can give you a false uh, positive.
So we have seen even in the treated cases, when there is no parasitemia, we cannot found any parasite in the blood. Uh, in the treated cases, even ICT gives a positive result.
Yes, correct. Right. So, what is the indication of exchange transfusion in malaria?
It's heavy parasitemia. I don't remember, but more than 30%, I think.
More than 30%. And cerebral malaria, or if the
Right.
patient is or if the patient is very ill because of the parasite infestation and the MDT decide that this should be treated by exchange transfusion. Usually, the patient is referred to infectious disease team or tropical medicine team. They deal with the malaria. And
And
what
it
drug?
10%, yeah.
Yes.
The parasitemia index for exchange transfusion.
Sorry, can you repeat?
And the parasitemia index is 10% for exchange transfusion,
30%.
30%. Oh, thank you.
And ideally, we do not deal with the treatment of malaria in terms of drugs, but if they ask in the exam, then they are the artesunate-based medication for um, Plasmodium falciparum. So remember the name of the drug for cerebral malaria, for leishmania, for filariasis. Uh, they will be asked in the exam. In real life, you do not deal with them, but for the exam purpose, remember the name of the drugs for these few infection: filariasis, trypanosoma, leishmania, and malaria. All right, the last case of the day. Okay, so this is again a 56-year-old man presented to ED with severe shortness of breath, failure, extreme tiredness. He's febrile as well. The full blood count shows hemoglobin of 70, platelet count of 405, and white cell count of 12. This is the blood film, and I want any biomedical scientists or lab staff to comment on the blood film first. Then I will go to clinical hematologist.
Sorry, how much was the white cell count?
12.
Okay, thanks.
Ignore these things. These are not parasites. This is just the oil related stuff moving here and there. Okay. So there is no biomedical staff or lab staff to comment.
Sir, the peripheral film of the male patient is showing anisocytosis in the red blood cells. There is polychromasia, macrocytes.
Mm-hmm.
Um, there are occasional teardrop cells.
Okay.
I want to see spherocytes, but there is central pallor in. I can identify the central pallor in many of them.
look like microspheros.
Some of them don't have. Okay. So as a biomedical scientist, I will report it as the blood film shows uh, an isopoikilocytosis with multiple polychromatic macrocytes, spherocytes, whole jelly bodies, and high platelet count, no platelet clump seen. The neutrophils are hypergranulated, suspicion of hemolysis secondary to any infection. The film is referred to hematology registrar for um, expert opinion. Now I need a clinical hematologist to report it for the purpose of a FRC path exam. Yes, anyone want to report it?
Yeah, I can try.
Yes. So you are sitting in the FRC path exam for two,
Not now.
and yeah, and this is the blood film for you,
Yeah.
and they want you to report it for 6 marks.
Okay. There is anisopoikilocytosis. Um, the two morphologic population are present. One is macrocytes, and the other is spherocytes. There are oval jollies in some of the cells.
Mhm.
Yeah, and the poikilocyte, I could see in the previous fields some teardrop cells as well. The neutrophils were having toxic granulations, so probably spherocytosis in splenectomized patient.
Okay.
Sir, if this is
And maybe
splenectomized
hemolysis as well,
patient,
as there are velocytes, and I could not see any polychromasia if there is.
These are all polychromatic cells,
Oh, yes. Yeah.
large macrophytes.
Yeah, so probably there is hemolysis also going on, and the spherocytes might be due to the hemolysis or maybe transfusion in a splenic-myased patient. The toxic granulations might point towards the infectious uh, trigger as a cause of hemolysis.
This one.
Yeah, Hovel-Jolly bodies, yeah.
The red cells are agglutinated. These red cells are agglutinated.
Oh, yes. But there is no marked agglutination. Yeah, this one. It's here,
Yeah. So
yeah.
this question in FRC path exam can come in two ways. One is standard way, which is the report the blood film, and second one is the enumerate 6 points in this blood film. So you would say for reporting, the blood film shows severe red cell anisocytosis. If you are saying anisocytosis or anisopoikilocytosis, mention red cell because there can be platelet anisocytosis as well,
Okay, thank you.
yeah, containing multiple polychromatic uh, macrocytes, microspherocytes or spherocytes, few teardrop cells, Howell jolly bodies. The neutrophil is hypergranulated. Multiple red cell agglutination are noted. The platelet count looks increased, but there is no anisocytosis in platelets. The blood film is most likely consistent with hemolysis secondary to infection. We need hemolytic screen and infection screen on this patient to rule out whether this is autoimmune hemolytic anemia secondary to any infection or not. So you commented on the blood film features. You give your suspected impression that this is hemolytic anemia secondary to infection, and you suggested hemolytic screen and infection screen. This can be autoimmune or this can be non-immune as well. But
Mhm.
looks like this is autoimmune secondary to infection.
Okay, and the Howell jolly bodies.
Hyposplenism. The
Okay,
patient the patient
maybe
may have
functional. Yeah.
the patient may have um, hyposplenic or low splenic function because of many reasons, because of ongoing hemolysis. Maybe this is not the first time he's coming to the hospital with hemolysis. Maybe
Mhm.
he had hyposplenic function because of other reasons. But there is whole jolly bodies. There is increased platelet count as well. So
Yeah.
in
Okay.
hyposplenic patient, you see whole jolly bodies and increased platelet count. And this platelet count can be increased platelet count can be secondary to infection as well.
Okay.
Yeah.
Thank you very much. Thank you.
What are the secondary causes of autoimmune hemolytic anemia?
Secondary to the connective tissue disorders, SLE, or autoimmune, other autoimmune conditions.
Yeah. So
So these are
categorize it. Yeah. Yes, go on. So categorize it in four groups. Secondary causes of autoimmune hemolytic anemia can be because of four reasons: cancers,
Mm.
blah blah blah, CLL, lymphoma,
Oh, yes.
infection, uh, CME, EBV, bacterial infection, pneumococcal, then immune SLE, rheumatoid arthritis, etc., and then post-transplant.
Okay.
Post
Thank you.
post transplant post hematopoietic stem cell transplant autoimmune hemolytic anemia is very common.
Yes, yes. So, thank
Mhm.
you.
And what will be the treatment of this patient?
Treatment of the underlying infection, underlying cause.
Underlying underlying cause. Yeah. Treat the underlying cause, the hemolysis will settle. Right.
So, Dr. Amir, in reporting of this case, you will set your peripheral findings are consistent with the hemolytic process. And here we have to mention what would be the most probable cause, or just we can say that its findings are consistent with the hemolytic process. And then we advise the hemolytic screen
So
and also that. Mhm.
as I mentioned in reporting, that this patient has um, the blood film is most likely consistent with hemolysis secondary to infection because this patient has red cell agglutination and hypergranulation of the neutrophil. And the patient was febrile as well in the history.
The agglutinations, they are not very marked.
Yes, they
And
are not very marked because the patient is very anemic and there are only few agglutination, but there are
and
present.
usually when we see agglutinations, On
Mm-hmm.
smear, we think of cold, autoimmune hemolytic anemia.
Yes, but agglutination can be because of the infections as well. Agglutination has a lot of causes. So the lab staff will warm this, and then he can repeat the blood film if there is a quite
And
significant rapid inflammation.
the non-immune causes of hemolytic anemia also includes infections as well as
Uh,
the autoimmune and the non-immune both.
yeah, so first you will do um, hemolytic screen to find out whether that test is positive or not. If that is positive, it is immune. If that is not positive, it is non-immune. And then, according to the guidelines, you will think about few things. Uh, whether first question according to the guideline, is there any hemolysis? Yes, this patient has hemolysis. Is this hemolysis immune? Uh, Confirm it by that. So if that is positive, now whether this patient has any blood transfusion in the last 3 months and any drug that he has recently taken that can induce autoimmune hemolytic anemia, any other cause. In case of infant, we think about HDFN as well. And if it is autoimmune hemolytic anemia, okay, what type? So that will tell you whether it is warm or whether it is a cold, whether it is a chard, whether it is a mixed autoimmune hemolytic anemia. Okay.
Yeah, okay, thank you.
Mm. So this was the last case, and
Sir, I have a
again,
question.
mhm.
Uh, After splenectomy, the patient peripheral may have nucleated red blood cells. What is the reason for this? How can we explain this? Because normally, if the patient are not splenectomized in the peripheral, he has no nucleated red blood cell. But after splenectomy, I have seen patient they have lot of nucleated red blood cells. So, sir,
uh,
what?
so uh, nucleated red blood cells can be present in severe hemolysis, like in the last few sessions when we had autoimmune hemolytic anemia patient, there were a lot of nucleated red blood cells. But this autoimmune hemolytic anemia does not have any nucleated red blood cells. If you have severe DIC and your bone marrow is under stress, you will have nucleated red blood cells in the blood film as well. If you have leukoerythroblastic blood film picture (MDS) or uh, blastoid CML or blastoid mental as well, the bone marrow is under stress. You will see multiple NRBC in the blood film as well. In splenectomized patient, which is usually in thalassemia and in sickle cell disease, uh, the spleen is the area of extramedullary hematopoiesis. When you remove the spleen, the bone marrow become under stress, and then the blood film is packed with NRBC. So NRBC is not only in the peripheral blood film after splenectomy, they can appear in the peripheral blood film after many reasons, because of many reasons. Severe hemolysis, severe infection, MDS, CML in blast phase, um, also the leukemic phases of follicular lymphoma, they all have NRBC in the peripheral blood. And thalassemia patient, because there is extramedullary hematopoiesis going on, spleen is very large. That's why you have NRBC in the peripheral blood. And in babies, in 2 days old baby, if you see the blood film of 2 days old baby, they will have a lot of NRBC in the peripheral blood, which is normal for them because their spleen is not yet mature. and the bone marrow is producing everything, and bone marrow is under stress. So
जी सर,
any reason which make the bone marrow under stress, you will get an RBC in the peripheral blood.
जी सर, thank you.
So these sessions are free, but if you want to donate, these are the account details. And if you want to give me a coffee, you can use this link and subscribe the channel. Thank you for that, and see you next week. Have a good
Thank you,
week.
Thank you,
Dr.
sir.
Amin.
Allah.
Thank you so much.
Thank you.
Inshallah.